So welcome to this series called the Perioperative Coach. In this series we have top tips on all aspects of perioperative care from some of the world's experts working together to enhance surgical recovery. Don't forget to look on the show notes on topmedtalk.com for additional links to papers, etc. And of course, if you haven't done it already, subscribe to Top Med Talk. Top Med Talk. So hi, I'm Monty Mythen, Editor-in-Chief of Top Med Talk. Welcome back. So I'm here with Mike Grocott, who's one of the visiting faculty from the University of Southampton in the United Kingdom. And we've got two other guests with us today, both from Duke University Medical Center. We've got Annemarie Thompson and Padma Gulur, who's been with us before. Padma, welcome back.
Thank you.
So Annemarie, you're new to Top Med Talk.
Yeah,
Welcome.
This could go south, Monty.
So we've been having a great meeting here, day 2, and this morning we were dealing with some big picture issues, things where we have opportunities to make a real difference to our patients here and now. A lot of things we can discuss are highly speculative. But if we start with our old friend pain management, and in particular where we stand with regards to opioids, Padma, we've interviewed you before relatively recently about the so-called opioid crisis. And within that, we've been recognising our possible contribution as opioid prescribers to the fact that some of these drugs can leak into the community, and perhaps we're helping some people inadvertently to become addicts. Now, as part of accepting responsibility for our relative contribution, we've been discussing pain as the fifth vital sign, and whether we went a bit overboard with that. And you referred to that in your talk. This sort of obsession with making all pain go away post-operatively, and the belief that somehow that an opiate, is the only thing that can really fix bad pain.
It's been quite a journey. I mean, back in the 90s, there was a time when we were not treating pain adequately, and that caused a lot of people to start a movement, really, to say that pain needs to be treated more appropriately. Pain as the fifth vital sign is a bit of a misnomer, because people believe that the Joint Commission instituted that as part of its accreditation of hospitals to make it the fifth vital sign. If you go to their website now, they actually have a detailed page denying that claim, or that claim to fame, right, and stating that they had never quite asked for that to happen. Now, it's controversial. There are different people who feel differently about that. But more importantly, their goal was to advocate for pain management. Yes. What was an unintended consequence is that pain management started to equal opioids or opiate management. And to the exclusion of all else, we started to prescribe opioids to manage this pain without adequate support, without adequate education around multimodal techniques, etc. And that has led to the prescription drug abuse epidemic that we're currently facing here in the United States.
So Annemarie, from your perspective, what did you feel as though you were under pressure to perhaps oversubscribe pain meds at one stage?
I remember during my internal medicine training, what was remarkable was the pain, the fifth vital sign sort of moniker came out. And that was, what it basically did is it supplanted what I believe is truly the fifth vital sign, which is oxygen saturation. You have blood pressure, heart rate, respiratory rate, temperature. Your fifth vital sign should be oxygen saturation. And I would say, tragically, that was supplanted by the idea that pain is your fifth vital sign. I distinctly remember that coming out during my training in the 90s, and the emphasis that was placed on doing that as a measurable outcome that hospitals were judged by. Interestingly, I would say both as internists, as an internist and as an anesthesiologist, I think everyone, not just anesthesiologists, has contributed to this current crisis. This was, at least by some organizations, considered to be a medical imperative, that we treat pain and that any pain score above 0 was unacceptable. So I do feel, just as a physician, regardless of the specialty, we have all probably in part been unwitting participants or contributors to this crisis.
Now, in medicine, over the decades, over the centuries, we have this tendency for the pendulum to swing right one way and then swing back the other way. We've seen that with fluid management. We went from drowning. More recently, we've gone to desiccation, and we've seen harm associated with that. So I don't in any way, shape or form anyone's saying we shouldn't treat pain.
Right.
And we should make patients comfortable, should
right.
be the objective. But Mike, in the UK, Do you think we had a similar journey, and what have we done about it?
I think we probably were a little bit more moderate. Clearly the alleviation of suffering is one of our core professional obligations, and I think so. My impression was that the pain as a fifth vital sign thing we heard, but was not fully adopted. What it did do was it made it easier to not think too much about prescribing pain medications. And as Padma rightly says, the unintended consequence of that was potentially over-prescribing.
We got into fixing the pain score, though, didn't we? We started to become obsessed, I believe, with having good-looking pain scores rather than functional pain relief. Is that fair?
We did, and given that pain is subjective and therefore in itself rather limited as a vital sign, all the other vital signs are measurable and objective, and it's also therefore very hard to measure. That was probably a mistake in the first place, and then a road that we continued to travel, causing harm, sadly.
So, Padma, you told us more about optimal pain management, and there's been a movement around the world now to have more functional pain scores, so to combine the ability to mobilise, for example, with comfort measures as opposed to the obsession with the pain score. Is that where you're going at Duke?
Absolutely. I think, setting expectations, I think more than even just the score, it was the expectations we were setting amongst the patients and the providers. When we said pain is the fifth vital sign, I think we started to send the message that you should experience no pain. It was less about the number, more about the fact that we were, by asking patients repeatedly about their pain, we made it seem like they shouldn't have any, as opposed to educating them appropriately that this is what we would consider appropriate as long as you're functioning. We really want to just manage your pain.
And the post-operative period for most patients having in-hospital surgeries, for most patients there is some degree of pain through to really quite severe pain associated with that. And in treating that, the opiate is just one of a very, very many large number of tools. And I think you divided into three broad categories of things we should consider to try and help patients, both psychological, medical, I think there's a physical, so it's not just the tablets and the meds, is it?
Oh, absolutely. The story is much larger. It takes a lot to manage pain, and focus it only on pharmacology, and that too on a small number of drugs or one class of drugs is really where we fell short over the last few years. And making sure that and pain by itself, is hard to measure, as Mike just pointed out. It's assessment is challenging because basically we don't have objective measurements. And pain means different things to different people. There's also suffering, the component of suffering, hence the psychological aspects of this, and helping manage it. Two people can have the same injury and experience pain differently for the same injury, and we have to recognize that and accept that.
So, Padma, so you're a pain specialist. So Annemarie, if I was to ask you what sort of specialist you would describe yourself as primarily, what would it be?
It'd be a cardiothoracic anesthesiologist.
Okay, so those ops, if you have a bypass and you have an open chest, for example, or thoracic procedure, they hurt a lot.
They do. It's not simply incisional pain. There's a lot of referred pain. So I work in the cardiothoracic ICU, so patients coming after thoracotomy will often not complain as much about the incisional pain, but especially if they have an epidural for pain control, but they'll complain of shoulder pain, which isn't covered by an epidural, which speaks to Dr. Gulur's point that expectation management is very important in these patients.
So your expertise, now we're all trained as anesthesiologists, anaesthetists, critical care docs, whatever it is, to be some degree of expertise in pain management. So we should understand the drugs and how to use the drugs. At what stage do you make a transition to call Padma or one of her friends to say, I now need those other tools to be brought to bear? Because I don't know how to subscribe the psychosocial support or whatever it is or get to...
I think identifying patients even as early as before they ever present for surgery, when they come to their surgeon's office for the initial visit, I think there are certain patients that could benefit from pain management expertise beyond what we all have learned as critical care intensivists or anesthetists in training. And those would be people who already take a high level of pain medication prior to surgery. Those patients can potentially be, without modification or optimization, be very difficult to manage in the perioperative period. So in those kind of patients, we would want to engage specialists in pain management for that.
So when you go down the list of drugs preoperatively and they're having cardiac surgery, for example, if they start to list pain meds,
Right.
It should be a flag.
Yes, well, and especially with the amounts. We can debate the actual amount, but in our preoperative clinic, a morphine equivalent dose of 50 milligrams or more is certainly a red flag that this patient may have trouble with pain management postoperatively.
So when that happens at Duke, what do you do now if you do get one of those patients?
So now what we can do in our PASS clinic, Perioperative Anesthesia and Surgical Screening Clinic, is by having enough lead time up into the surgery. We want to see those patients as soon as possible after they consult with the surgeon about surgery. We can refer them to our perioperative pain management clinic, which specializes in taking care of these at times incredibly complex patients to try to avoid some of the problems with readmission, respiratory depression, overdosing that can occur following surgery.
And then, Padma, if your team, your specialist team, makes a decision to support said individual as part of their care package, they enter this, is it right, the perioperative pain care continuum? Mm-hmm. So you're in for up to 90 days, is that right?
That's correct, for 90 days after surgery.
So we're here with you from
We're
now.
walking the entire journey.
Okay, and with that brings a specialist team that includes nutrition, pain psychologists, physical therapists. It's a whole multi-faceted, multimodal team.
Absolutely.
Now, if as part of that, so Annemarie's identified the patient, well done Annemarie, flagged them up, referred them to you, you've shown them lots of additional support and love out to 90 days. There's always going to be, particularly for thoracic patients, for example, there's going to be a subset of people who look that pain is going to be an issue for life now. Mm-hmm. So at what stage do you refer them as with a badge of chronic pain of some form for extra support? So
immediately after surgery, we're actually at the first visit after surgery when they come back to us, we're looking to see how they're responding to the post-surgical episode, and we start to educate those that we suspect may have persistent postoperative pain about the fact that this may be persistent, that they may have more chronic pain issues develop from this. So it's really as early as that we start to engage in the conversation that they may need chronic pain care and engaging them with those specialists, encouraging referrals to set it up. The reason we do that is here, access into these chronic pain clinics is not immediate, and therefore it can take up to a month or two. Okay. So we prepare them in advance to say, you should get your referral in because you may need it. You may need this appointment. Because we'll take care of you up to 90 days, but should it persist past that, it is chronic pain and you would need extra support.
I think you've shown us before some of the results. It looks to me like it's having a big impact. It looks like it's being financially highly effective as well. Is that your impression, Annemarie? I'm going to call you a user now, if you see what I mean. Is that someone who's throwing up the red flags and referring them and then getting them back on critical care and hoping for that extra support? Is it a reality?
Well, I think when you look at it, it does provide value. If you look at patient outcome, there is probably no better patient outcome than ensuring the safety of a patient when you're talking about things like respiratory depression, cardiac arrest, readmissions, inadvertent falls, accidents related to the overprescription of these kind of medicines. The patient outcome is there. The cost, in my estimation, for to be seen by a specialist is minimal by comparison. So I do think it is of great value.
So, Mike, we're pretty mean in the NHS when it comes to throwing money at things that we don't think produce high value. What's it like at Southampton? Do you get similar support? Or do you think you should get similar support?
I think we should. Until relatively recently, we've had, in comparison with many other institutions in the UK, very modest support for pain, although that is developing at the moment, and we've got some great new members on faculty.
So at UCL, I think we've been quite privileged by having a high level of interest from our chronic pain teams and acute pain teams working together, and Padma met some of our teams over there.
Fantastic faculty.
Think we're pretty well served where we are. We've been convinced it's value for money. It's hard to get the resources.
It's really hard, but I think we're enthusiastic to make that case. And actually the development of the perioperative medicine team rounding after surgery is an opportunity to do that relatively efficiently, in that we're not necessarily asking for a pain team to go around and a perioperative medicine team to go around. We can attempt to combine the two and have one or two people providing the pain expertise into the perioperative medicine team.
Top Bed Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. Have a look, ebpom.org/meetings.